You are listening to the 5-Second Rule podcast presented by APIC, the Association for Professionals in Infection Control and Epidemiology. This podcast is produced by the APIC Communications Committee and is intended to be a conversation between our hosts and professionals practicing in the infection prevention and control industry. You will learn and be entertained, but most of all, we hope you will be inspired by our community and the work of our peers. And now, on to the show.
Welcome to the 5-Second Rule podcast. We are your hosts. I am Lerenza Howard, and my preferred pronouns are she, her.
And I'm Kelly Holmes, and my preferred pronouns are also she, her.
We have an amazing episode in store for you today with a couple of guests. First, we have Dr. Becca Crapanzano-Sigafoos, also known as Becca, is the Executive Director of APIC Center for Research Practice and Innovation. Becca has practiced infection prevention and infectious disease epidemiology for the last 20 years in a variety of healthcare settings and has numerous publications focused on infection prevention staffing and endoscope safety. She received both her Bachelor of Science in Public Health, Health Education, and her Master's in Public Health and Epidemiology from East Tennessee State University. She completed her doctorate in public health in 2021 with a dissertation topic of assessing efficacy of an evidence-based Clostridiodes difficile screening tool using electronic medical record data. She has been certified in infection control since 2008 and is an APIC fellow. Most notably, though, Becca is the mother of 6 amazing daughters, ages 10 to 27.
And I would like to introduce Frankie Catalfumo. Frankie is the Director of Practice Guidance and Health Equity at APIC and their Center of Research, Practice, and Innovation. Frankie is an infection preventionist with more than 10 years of experience leading collaborative initiatives within acute healthcare and the federal government. In his current role, he oversees the development of practice guidance tools that are meaningful to the association's membership. He also leads investigative work regarding the relationship between health equity and infection prevention. Prior to joining APIC, Frankie led infection prevention initiatives at Innova Health System, the Johns Hopkins Hospital, the Department of Defense, and the Centers for Disease Control and Prevention. From the global HIV epidemic to the threat of multi-drug-resistant bacteria, all infectious agents prompt the need for effective prevention and control measures. Frankie is board certified in infection control and in sterile processing. Welcome, Frankie and Rebecca. We're so happy to have you.
Thank you. Glad to be here.
Thank you all so much.
Absolutely. It's such a pleasure to have you both on the show. And of course, we're focusing on the CAUTI Implementation Guide, the newly updated CAUTI Implementation Guide. So just for everyone's knowledge, this guide was developed by the Practice Guidance Committee with support from APIC Center for Research, Practice, and Innovation. But for Becca and Frankie, for those of us that are not familiar with this, can you share more about the Center for Research, Practice, and Innovation and what role they play within APIC?
Absolutely. So the CRPI, as we call it for short, is a new division of APIC, and our focus is really trying to create clear and concise pathways from the generation of evidence, looking at best practice through the dissemination of practice guidance and implementation tools. We oversee a number of committees and task forces, including the Practice Guidance Committee, Health Equity Committee, Emerging Infectious Disease and Disasters Task Force, the Corporate Directors Council, and then the growing research arm of APIC as well.
Absolutely. That's amazing. That's very amazing to learn of the research arm related to APIC and the advancements that you all will share with us today.
Ooh, yes, I agree. I'm so excited about this new CRPI and the guidelines that are starting to come out from it and the staffing calculator, which was awesome. So today, as Lerenza mentioned, we wanted to talk about the CAUTI Prevention Guide. So could you please tell us what motivated the development of the CAUTI Prevention Guideline? And can you walk us through the key principles that are listed out in the guideline?
Absolutely. So In last year in 2024, the Practice Guidance Committee took a look at all of our implementation guides and really tried to understand which ones do we need to update. And CAUTI was slotted first for two main reasons. One, the previous guide was all the way from 2014. So in the 10 years time, there's been a significant amount of advances in clinical practice and practice guidance. So we wanted to go ahead and refresh all the content in the CAUTI guide. And additionally, this is applicable to every single IP, which is incredible. If you're a novice or if you're an advanced IP, anybody can peek inside this implementation guide and get more information out. And we really decided we as a collective practice guidance, Becca, myself, wanted to really rethink and refresh in these implementation guides. And we wanted to focus on including things that are harder for IPs to facilitate in the hospital. So we focused a lot on adding some sample tools that we think would be most helpful in the implementation guide. So we ended up including a few things in the implementation guide, such as an acute urinary retention pathway sample tool, alternatives to indwelling urinary catheters, things that IPs really need to help move that practice forward. So there's a lot of notable things in there, but I think those two sample tools really help distinguish this whole update that we've been waiting for, and the applicability to all IPs is absolutely incredible.
That's absolutely amazing. And I know that from us IPs, it's much welcome to be able to have these resources and even the tools that you noted related to retention to assist us in implementing some tools in our organization without having to reinvent the wheel. But with that, I know with facilitating, CAUTI prevention initiatives, there may be some, misconceptions related to CAUTI prevention and or what role everyone plays within CAUTI prevention. So from your purview, Becca, what are the most common misconceptions about CAUTI prevention in healthcare settings today?
So, yeah, that's kind of a hard question, but I think really it's less about misconceptions and more about lack of full understanding of all of the potential factors that can impact CAUTI rates. So CAUTI prevention is complex, right? We've been doing it a very long time, and we're really good at the bundles, and where those basic things of keeping the bag off the floor and making sure things are secured, all of that. There are more complex things that are no longer, or that are not low-hanging fruit for us to really dive into, though, and we try and call those out and provide information about them in the guide. So I think one of the key areas that you can see in the guide we focused on is this interplay between diagnostic stewardship and antimicrobial stewardship. So understanding that if we are testing appropriately, that we are going to be impacting our antimicrobial utilization and potentially lowering our rates of antimicrobial utilization. So, there's lots of other things I think we can talk about when we look at the risk factors for CAUTI, but those are two that I think are most ripe for discussion right now.
Absolutely. I agree with that. I know that, especially as it relates to CAUTI initiatives, really bringing it home to the stakeholders, including executive leadership, as you were noting, cultural, I should say, diagnostic stewardship and antimicrobial stewardship is absolutely integral. And then relaying that messaging on what is the impact on the patient, right? The quality of life, the length of stay, the antimicrobial administration, and the development of MDR, subsequent development of EPDROs. So absolutely important.
Mm-hmm. Yeah, one of the things that I have always loved about APIC's guidelines is they're so easy to read. If you're diving into the literature and some of the more complex, journal articles that are out there, it can be a little overwhelming. But I think, what APIC has done such a lovely job of is pulling out all of those best practices and putting them into a very easy to read, digestible format. And, like Frankie alluded to, whether you're brand new in infection control, you've been doing this for 20 years, it's It's easy to read, easy to implement, fantastic. So that being said, you've laid it out for a nice roadmap for us, but what barriers do you anticipate that hospitals and healthcare facilities might face when they're implementing some of these strategies that are outlined in the guide, and any tips to overcome those?
I think this is always going to be a tough one for many IPs, and it's about who owns the process and how exactly you can add value within your IP position. So, understanding who are the stakeholders, who are those process owners, what is the difference between a process owner and support staff? Because as an IP, we are supporting everyone. We're helping to connect the dots to reduce these HAI rates. And when we're not the process owner or the driver, it can become hard to connect all those dots to make sure people can understand, why do we need to bundle? Okay, when the bundle's working very well, but we're still having HAI rates, what else can we do? So I think stakeholder management is the best piece here. And I have a saying that I use quite a lot. When I experience difficulty in the hospital, I just partner harder. And I encourage everyone to just partner harder with anybody who is a stakeholder. If you need to partner harder with the nurse, partner harder with the nurse. If you need to partner harder with EVS or a pharmacist for antimicrobial stewardship, do so. But understanding who's in your corner and getting more people in your corner, kind of like Survivor, if you will, is really one of the most difficult parts, but the most enriching part, because once you find that magic and you get everyone to be your best friend and supportive of your intervention, that's when you can start moving that needle.
I love that, Frankie. Definitely adopting or having an advocate to push forth your efforts. That stakeholder management is absolutely integral. And I love the way that you framed that as far as the process owners. We are the support staff as infection prevention. And, of course, we as IPs experience that challenge in organizations that don't fully understand what that equates to. But I really love that the CAUTI guide, it does list out the respective stakeholders that would be affiliated with the CAUTI prevention measures and those that will be integral, including also the physician and nursing team. So, of course, there are various, varying resources that are accessible to healthcare organizations. Say, for example, even with the EMR, some have access to EPIC, some are still utilizing Meditech. So, how does the guide address differences in resources available to various healthcare settings, from the largest of organizations to the smaller critical access hospitals?
Yeah, I think, creating a one size fits all tool is a really difficult thing. And so instead of trying to do that, we try to create a toolkit or a toolbox that is full of lots of different tools that an organization or an IP can select based on their own specific needs. So, depending on the size of the facility or the type of facility, there are parts of this implementation guide that might be very applicable, and other parts that you might just tuck away for later use. One of the key areas that I'm most excited about as an epidemiologist myself is the addition of the epidemiologic questions section. And this is really a tool for an IP to use if you're seeing a trend in CAUTIs, and it provides you with a number of questions to ask yourself as you go through your line listing and you look at the CAUTIs that you've had. It's a list of epidemiologic questions to help you understand, might there be some connection here that I haven't thought of yet? And perhaps not, but after answering all those questions, then you'll have I think, a better, broader perspective of what's potentially happening. Oh, go ahead.
Oh, I just was going to jump in and say that I'm so glad you brought that up, Becca, because I noticed that in the new guideline and thought, oh my gosh, how helpful this is, especially, with newer people that are in the role, newer IPs. I think we typically identify a CAUTI, and then it's best practice to kind of have a meeting with, to drill down on, with the care team, like what happened, asking the 5 whys, trying to get to that root cause of what, maybe perhaps caused the CAUTI so that we can prevent that type of thing in the future. And people ask me, well, what questions do I need to take to this meeting? How should I be prepared for this meeting? Oh my gosh, I have to lead this meeting. What am I going to say? And I feel like that list of epidemiological questions is such a good starting point for, the discussion to really drill down on, what could be the focused cause of that particular infection. So love that.
I love to hear that. And I think too, when utilizing this tool, folks can add to it. And, if there are unique things at your own organization that you find that, you'd add to the list to ask for future outbreaks, I think that's exactly how the tool should be utilized. And when we look at downloads, since the tool was launched in March, there have been a little over 2,500 downloads. And so it seems like this is an applicable tool, a tool that folks are willing to take the few seconds to click the download button. We're excited about that. We're excited to get feedback from people on, things that we should add to future tools, because there will be lots more like this coming.
Absolutely.
Yeah.
I am one of the 2,500, I will say. So that's remarkable.
I know. Me too. So 2,498 or whatever. Yeah. That are not on this call. And Frankie, did you have anything to add there?
Yeah. As Becca mentioned, this is the first of many implementation guide updates. And as she alludes to, we do want to keep this to be kind of a living document. We don't want to wait another 10 years to update this. So as we see things change, we may add appendices on, and we'll work with our practice guidance committee to do so, to make sure that we can stay ahead of the practice. Sometimes in infection prevention, we don't get a significant runway to make any changes. We know that we're busy, we're short-staffed, there's resource issues, but having an appropriate runway when something changes to then guide your practice is wonderful. So we're hoping to do that with a few appendices in the future as CAUTI evolves.
I love that. I also noticed in the guideline that it's laid out in a couple different sections when you're talking about best practices, and you have a section that is for the essential practices, and then following that you have the additional practice section, which deliberately aligns with the Shea Compendium and kind of, the way that they lay out their recommendations as well. So for our listeners, could you explain, like if I'm looking at this, as a new IP or even a seasoned IP, and I'm like, oh my goodness, there's pages and pages of practices to implement. Where do I start? Can you kind of walk us through the difference between those essential and additional practice sections?
Yes, and I think this is the bare minimum. If you're going to download this once and just take a quick sneak peek, you can go ahead and go directly to page 16. And you can go ahead and start looking at all those essential practices, which a lot of y'all should be familiar with these, because these are our typical bundles. These are our bread and butter. This is what we kind of look for when it comes to our RCAs and ACAs. And we give you recommendations for implementation task for that bundle element. So if we're going to be talking about using the proper technique when collecting urine during cultures and transport, we're going to give you a few recommendations. So that way, maybe if you're feeling like during an ACA, RCA, there's some issues, you have some implementation tasks to look at, and then you also have a rationale. So that's just for the essential piece. But really, what's novel and what's very exciting about this new edition is the additional practices. So we're taking all of the research that is out there that hasn't really made its way to evidence-based guidelines yet, and we're putting it out there as potentials to consider. And we even tell you when you should possibly consider it. An example is bladder scanning algorithms. So we talk about the description, we give you recommendations on when to consider it, and then we point towards a source that you can actually dig in more to. So there's fully free EDs, another mention of an additional practice, but all these pieces haven't made it to evidence-based guidelines. So some IPs are maybe doing this in large academic centers, but we want it to also be available to those community health centers, those critical access hospitals that are having issues, but their bundle elements are wonderful. This will help you all improve the practice.
Yeah.
One other thing I'd like to point out too that we do in this implementation guide is at the beginning of each section, we try and provide some some background information regarding the content. So like prior to presenting the essential practices and advanced practices, we explain the difference between evidence-based guidelines, expert consensus, et cetera. And I know thinking back a lifetime ago when I started in IP, that was so unclear to me, and that it took me a long time to really understand the process of how guidelines are created versus how standards are created, and the nuance of those things. And so we're hoping with just those small sections of explanation that we're able to help folks really understand with greater depth.
Absolutely. And
Yes.
I agree with, what you were noting, even Frankie. And I also think that it's a good tool for those that may not have comprehensive guidance in or the development of bundles that are existing. It provides, some level of foundational information for them to take back with the clinical team for there to be a comprehensive development of a multidisciplinary CAUTI initiative within their organization to investigate the evidence-based practice and its applicability within their organization.
And in a post-COVID world, I think it really helps bring us back to the basics with those essential practices. You can be spread so thin with trying to do all 100 things. But if you kind of pull back and really do a gap assessment, really line up those best practices, those essential practices, where's your facility meeting those essential practices? And if you're still having issues, then yes, let's dive into that additional practice section and see what might help our situation. I love it.
Yeah, work smarter,
Absolutely.
not harder, right?
Yep.
Exactly, Becca. Even with that bladder scanning tool, I'm pretty sure, of course, the larger organizations, they may have access to this, but for those critical access hospitals, where those tools aren't, readily or may not have been developed yet, this is something that they can definitely use and leverage within their organization. But I'm curious to know, of course, some institutions may leverage technology such as even EPIC, as I was noting previously, as far as maybe incorporating components of the bundle, CAUTI bundle, within the EMR so that there are different alerts that may go off to ensure that the bundle is being adhered to. So, as it relates to different technologies that could be utilized for CAUTI prevention, tell me from your purview, Becca, how has technology influenced CAUTI prevention in any way? And are there any tools or any technological advancements that you're particularly excited about as it relates to reducing this infection type?
So when I think back, I have enough experience in IP to remember a time before NHSN, which some of our newer folks might say, "Wait, what? There was a time before NHSN?" But there indeed was, and we made a lot of headway in just the measurement of the way that we do surveillance and all of those things, and that's wonderful. Like now. It is rare that an IP has to walk around a unit and count how many people have a central line and count how many people have a urinary catheter. And so as we sort of move into what's next in that world, I think what's most exciting for me is leveraging the electronic medical records as decision support tools. And primarily in, Lerenza, you spoke a little bit about measuring bundle compliance and having alerts that prompt us to, don't forget to document that you checked securement and, you checked all of the bundle elements. But moving into things like providing decision support for providers that are placing orders for urine culture and helping to really guide those decisions so that we're not over ordering and potentially identifying things that aren't truly CAUTI, and then resulting in patients getting medication that may not be appropriate.
Absolutely. That brings me to a thought for both you and Frankie. What role do you envision patients playing in preventing CAUTI? Is there a role for the patient in preventing infection? And do you have any strategies that people could implement to help patients advocate for their own care?
Really, when we talk about patients, what's most important is a patient feeling empowered, like empowered that it is appropriate for them to question things in the healthcare environment. It can be really intimidating to be a patient and to feel like you're surrounded by professionals and they know what's best for you, and to, feel uncomfortable asking questions or, sort of stopping the line about things. And so I think looking at ways that we can help patients feel more comfortable, really encouraging them to speak up when something doesn't seem right, will benefit healthcare organizations in the long term by reducing potential errors.
I completely wholeheartedly agree with this. I think empowering them to advocate for themselves and to ask questions, I think a great way that even IPs can help patients begin to learn is, if they have any questions and you're rounding with a nurse or a provider and you're doing your CAUTI rounds to look at those bundle elements, you can include them in information there just to start them in the process. There's certain ways that you can get them on board. CHG is a huge one as well, getting CHG treatments to decrease the bioburden. There's a lot of patient education that is starting to come out that is super complementary to IPC practice. And I look forward to seeing how that trickles down to patient engagement.
I'm glad that you noted that the patient empowerment is definitely integral in HAI prevention, and even as they, are subsequently discharged home and caring for any devices that they that remain. As you noted, while you're doing those device rounds, and I know I apply that within my practice, is just educating the patient on, what it is that you're doing, and also, say for example, as you noted, CHG, educating the patients on what it even is, if there's a lack of awareness related to that, and the importance of ensuring that it's performed. Also related to their urinary catheter, say for example, if you have a patient that's possibly pulling and tugging at it, just, also translating the information that you're sharing, not only with the clinical team, but also with the patient as well, is integral. So on that note, I would like to know, of course, this CAUTI implementation guide provides us with some foundational tools and knowledge on implementing measures and preventing CAUTI events. But I would like to know what tips and tricks or words of advice you would share with any healthcare professional, not just infection preventionists, who aspire to lead a CAUTI initiative within their organization. What advice would you give to them? Frankie, let me hear your insights.
The biggest piece of advice that I could get is learn from the experts around you. We all are within our own wheelhouse. And when we can approach with curiosity, we can deepen our engagement and collaboration with those people. When I did my device rounds, Lerenza, I'm not an expert. I'm not a nurse by background. And I always ask them, like, you're the expert in this. Can you tell me what you see? Can you tell me why you're doing these things? You're building rapport with a lot of people. And this actually goes back to some of that stakeholder engagement as well. You have the stakeholders, you need to build relationships with them. They have an expertise that you don't. So approaching people with curiosity and learning from them to then build that collaborative effort to build on top of that stakeholder engagement. I think it just starts with that kind of openness. IPs, of course, if we spot something, and this is specifically for IPs, if we see something that's wrong, we normally jump right in. But, asking people, hey, is something wrong here? Why did this go wrong? Just trying to do more background to understand the process of how that happened could really help lead to reducing all those downstream impacts so you can work more upstream.
I
Frankie,
absolutely agree. Becca, would you like to share any insights?
Yeah, I was going to say I couldn't agree more with that. I think that really seeing ourselves as support for, the folks that do the work is an important perspective, and approaching each situation with like Frankie said, with curiosity and with humble inquiry, right? Not like nobody comes to work to do the wrong thing, right? Everybody comes to work and attempts to do their best. And so our job is really to help folks figure out why something might not be working, versus trying to come in and save the day and point out all of the problems.
Absolutely.
I love
Absolutely.
that. I love that note of humble inquiry. I think that that's absolutely integral because, of course, we can come out and point everything that's wrong, but it's really necessary to display that posture of, as you noted, humble inquiry, just asking open-ended questions. And of
Right.
course, as Frankie noted, no one, not having that assumption that there was an intent to do any wrong in that regard.
And really building those relationships. And Frankie, again, tell us what your catchphrase is.
Oh, partner harder.
Partner harder.
It's
Yes.
just, and I said this, I say this as an IP a good bit, is I don't care if I have a problem. I care how we solve it and you bringing it to me so we can solve it. And honestly, we all remember a situation of a staff member coming up to us and they're just like, I need to tell you something, but I'm kind of afraid. And you're like, oh, this is a great problem to have. Like, thank you so much. And that's when you figure out that your partnering harder is actually working. When people come to you and they're afraid to tell you something, but they really want to, you've earned their trust, you've earned their respect. They feel like you can actually benefit them with your expertise to complement their expertise. So partner harder, like put it on a bumper sticker. It's magic.
And then it feels like a team effort and everybody moving in the right direction instead of, oh, I caught you doing this or this was wrong. Or I love that. Partner harder. I'm writing that down.
We'll have to see if we can get T-shirts made to sell at conference this year.
Let's do it.
Well, APIC is
hashtag partner harder. Oh, so you mentioned you kind of teased us that some new things are coming down the pipeline. So could you give us any hints on what the next guide is that you're working on?
The hint is it's going to be here super soon.
Yay.
And we're very excited to actually, this is going to be the first formal kind of push, really, Becca. So more exciting. So we have our CAUTI Implementation Guide that will be retired because we're expanding to all vascular access devices. So when I was talking about giving a runway as well for IPs, we know that some BSI surveillance definitions will be changing in the future. We don't have a date for that yet. So we're working on a CABZ guide, so a catheter-associated implementation guide right now, which will actually launch right before conference. So if you get the opportunity, click that download button. We want to smash some new records. And we also want to give you that runway. So when this surveillance definition does change, you'd be like, APIC had us. We got it in the bag. We feel super comfortable. You can tell I'm just too excited for words.
I'm excited as well. That is awesome.
Yeah, I'm really excited for that too. And just, it is the appropriate next step, right? We've been looking at catheter-associated BSIs for many, many years, but what about all those other BSIs with midlines or peripherals or any other vascular access device? So it allows us to really protect all the patients with all their devices. So I'm very excited about this.
Yeah, we are as well. Absolutely. And, just thinking about things on the horizon too, I would hate it if I passed up an opportunity to plug another thing that is coming at conference and launching at conference. And I think it's been 5 years since we've done it, but folks remember the APIC Mega Survey, and 2025 is the year of the APIC Mega Survey. So you will start seeing, as of the first day of conference, QR codes and links to be able to take the survey. You'll receive an email with it. This is a really important opportunity for IPs to tell us about the practice of IP and to help us to then be able to share that with the rest of the world. So our goal is 7,000 responses to the mega survey, which is quite a bit more than we've ever had before. But the volume like that will make the data much more powerful. So when you see that email come through, pretty please click the link and spend the time to tell us about your practice.
I know I'm eager to see the results of the mega survey. As someone who has utilized the information and definitely asked, when is APIC going to conduct another mega survey? This is news. I love this. Frankie?
And this is a refresh as well, so it is more newer. So definitely want to hit that 7,000 hashtag goal digger, because we are digging for goals. We are putting everything, all this data into action and digesting it and then putting it back in resources. So the more information that we can gather, the better our resources will be, the better IP practice can be in the hospital, the less lifting that you potentially have to do because APIC will do it for you. So
Mhm.
it's really building IPs at its finest.
Absolutely. I love that we get to contribute, right? And have our voices heard, and the amount of information that comes out of that mega survey and the way that it drives practice back to benefit then the IP and the patient. I'm really excited about it too. So everybody listening, make sure you complete the mega survey.
Exactly. And just to clarify, Becca, those that will have access in person will have access to this mega survey if they attend in person, and also those that are attending virtually will have access as well.
Actually, everybody will have access. So all APIC members, and this year we're actually opening it up to non-members as well, because we really just want to understand, as broadly as possible what the profession of IP looks like. So that link will be shareable. We'll share it on social media, but all members will get it via an email.
Thank you for that. Well, Frankie, Becca, of course, we can continue this conversation until the end of time. But of course, it has been a pleasure discussing the CAUTI implementation guide with you both. And we thank you for sharing your knowledge with us on today.
Yes, thank you so much. I'm walking away with Partner Harder. I love it.
Thanks for listening to APIC's 5-Second Rule Show. We want to hear from you. Visit us at www.5secondruleshow.org. That's with the number 5, where you can contribute to the conversation. Make sure you subscribe and rate us wherever you listen to your podcasts. We're so appreciative of the hard work each of you do every day to make a safer world through infection prevention. Remember, IP stands for Important Person. You are awesome. Stay safe, and we'll see you next time.